Hi everyone, welcome back. We're going to continue our discussion about atrial fibrillation because I've gotten so many questions about this and because it's the most common abnormal rhythm in the world. So many of us either have it or know someone that has it already, or might want to share this information with our family members, so it's very important. So we're going to continue that discussion, but I wanted to answer a question that came in before. This question is, do I go out and give seminars? The answer to that question is yes, but we do have to schedule ahead of time. If your group is interested in me coming to present a seminar, go to my personal email. That's Heartwise, one word, J as in Jim, M as in Marcum, heartwisejm@yahoo.com. Be happy to go, and we travel quite a bit. I have a great time interacting with people and ministering to them, so I enjoy doing that. But before we start today, let's look at a biblical prescription. And biblical prescriptions are very important. In fact, in one of the upcoming weeks, I'm going to tackle the question that's come in is, how do I know that the Bible's true? And I'm going to answer that with some science and some data for those that might not believe the Bible is true. God has given us evidence out there in addition to our faith. But let's read Acts 20, verse 24. And this is Dr. Luke talking. He's writing this and he's talking about some of the things that are going on in the ministry of Paul. But none of these things move me. Do I count my life dear to myself, so that I may finish my race with joy and the ministry which I receive from the Lord Jesus to testify to the gospel of the grace of God. So I want to encourage everyone, if they have a chance, to go into the Bible and read it, listen to it, and see how it applies to your life, especially as it pertains to health. So hold that with you as we talk about atrial fibrillation. Remember, atrial fibrillation is when the top part of the heart, we talked about it last time, you might want to review that video, the top part goes fast. It doesn't contract rhythmically. We usually make the diagnosis with EKGs, monitors that we make it. So when a person has this diagnosis, how do we work them up? What's usually done? Well, I want to explain this to you so you won't have to worry about it if you have it in the future or a loved one, but this is what usually happens. So you have the diagnosis. The next thing your provider is going to do is do a careful history and physical. Specifically, they're going to be looking at the different things in your history that might make you at risk for it that we talked about last time, how long you've noticed going out of rhythm, whether you're having chest pain, how you're breathing, how you feel in it. Remember, we talked about some people don't even feel it at all. Some people seem to be very debilitated by it. But some of the testing that we usually do is we want to look for the reason why. So we do a battery of blood tests, looks at electrolytes, the thyroid, looking for infections. We usually do an x-ray. This might tune us in for problems like chronic obstructive pulmonary disease. We ask to see if they might have any other lung problems like sleep apnea or infections, which can trigger arrhythmias. The blood work helps us know about thyroids, electrolyte deficiencies people might have. One of the most important tests we do is the echocardiogram. People ask me if an echocardiogram hurts. No, this is a sound wave test of the heart, and it gives us lots of information. It tells us the strength of the heart, how the valves are looking, whether they're leaking. It also gives us the size of the atrium, which is where this arrhythmia is coming from. It gives us indirect information about the lungs and the pressures in the lungs. It tells us if we are in a good chance to keep it in rhythm. So the echo is a very useful test. Sometimes, if we think that blockages in the arteries are causing it, we do more testing looking for that, either a stress test or we can look up and do an angiogram. We also have CAT scans now that can look for blockages if the history takes us in that direction. So we spend a lot of time looking for the cause with these tests, blood work, echoes, chest x-ray. The history really tells us what direction we need to go. And sometimes the atrial fibrillation is the only problem a person has, but sometimes it might be in conjunction with many other medical problems. And we have to sort of wade through which is the most serious problem going on. Is the atrial fibrillation the primary problem or is it secondary? And if it's the primary problem, what's causing it? And we talked about sometimes we look at all of these things, and if we can find out the cause, I had one fellow the other day that was drinking too many Red Bulls. If he would quit drinking the Red Bulls, then his rhythm would be better. Sometimes it's other triggers like too much caffeine, an overactive thyroid. And if we can get those things corrected, then the atrial fibrillation sort of takes care of itself. An easy one for us is electrolyte deficiencies. I had someone a couple of weeks ago that was magnesium deficient. We gave them magnesium supplements. Boom, their heart went back into rhythm. And hopefully if they'll keep the magnesium levels up, it will stay in rhythm. But atrial fibrillation is a trip. It's a journey. It's there with you. Sometimes it's once and done, but usually it's a condition that stays with us as we age and as we get older, and how to handle it depends on each individual circumstance. So we've made the diagnosis. We've looked into some of the things that cause of us. What are some special considerations? Well, before I really recommend treatment, I want to see the big picture. One, is the atrial fibrillation causing the heart to fail? Is the patient in heart failure? And that might be manifested by not being able to breathe because the fluid won't get out of the lungs. It might be swelling. Is the heart in failure? Because if it is, we treat that situation a little more urgently than we would if it's not. The second is, how long have we been out of rhythm? Remember, if you've been out of rhythm a long time, it increases a person's risk of the blood being still and having a blood clot. If they've been out of rhythm a long time, sometimes if they're not having a lot of other problems, it's safer to go ahead and thin out the blood to make sure they don't have a blood clot, which could cause a stroke. A stroke is a major complication of atrial fibrillation. In addition to heart failure, stroke. I work in the hospital and I probably see one stroke a week that is secondary to atrial fibrillation. Some people don't even know they have atrial fibrillation till they have their stroke. The neurologist calls me and they find out the person's had a stroke, and then they do an EKG and they find the patient's in atrial fibrillation, and the patient didn't know that their heart was going like this, the blood wasn't passing through, a blood clot developed, and boom, it went to the brain. A lot of times when people come in with strokes of uncertain etiology, we put them on monitors for long term just because atrial fibrillation is such a common cause of stroke. So that's a very important consideration. Heart failure, stroke, and the third is the quality of life. Is this atrial fibrillation debilitating a person so they can't do what they want to do? Some older people don't even feel the atrial fibrillation. It doesn't bother them at all. So we might take a different approach to them as we might have one that bothers a person a lot. And I've seen so much atrial fibrillation in my 30 plus years of cardiology. I've seen every variety that can be imagined. Some people goes fast. They don't even know they have it. I say, did you know your heart's going 150? They don't even feel it. Some people feel it a lot. Well, one concern that we have is the heart goes fast for a long period of time, it can make the heart weak. It's just like running a race. The heart gets tired and gets pooped out. And when that happens, we say a person has a tachycardia or fast heart rate that's made the heart weak, that's caused a cardiomyopathy. So a tachycardia-induced cardiomyopathy is a consideration in atrial fibrillation as well. So we look at heart failure, the risk of stroke, the quality of life, and whether the heart's weak from going fast for a long period of time. And then we make recommendations. And there's usually 3 classes of recommendations that's given. One, sometimes we say, let's put the heart back in rhythm right now. Of course, we want to make sure there's no blood clots floating around in the atrium, and we can do that with the test called a TEE, where they swallow a probe. We look at the atrium, make sure there's no clot. We can put them back in rhythm. If they're at very low risk or been on blood thinners already and there's no risk of clot, then we can go ahead and put the heart back in rhythm. Now, sometimes we can put the heart back in rhythm by what we call cardioversion. Now, what a cardioversion is we usually put some pads on a person, we sedate them, and then while they're asleep, we give them a small electrical shock that brings the heart back into a normal rhythm from the sinus node and not from all of these spots in the atrium that we've been talking about. And sometimes, especially if we get at the underlying cause, the atrial fibrillation might not come back for a long period of time. But usually, based on their risk, we usually put them on blood thinners because if it comes back and they don't know it, we don't want them to have a clot. And sometimes we have to put them on medicine called antiarrhythmics to lower the risk of them going out of rhythm. So that's one approach, is putting the heart back in rhythm, either with a shock right away, or there's some medicines that we can sometimes use that can put them back into rhythm right away. So that's one approach. And it depends on a person's individual situation, all of the health aspects they have going on. Another approach, especially if it's not bothering them very much, we don't know how long they've been out of rhythm, it doesn't bother them, the heart's nice and strong, there's no heart failure, we just control the speed of the heart, usually with the medication. Beta blockers, calcium channel blockers are frequently used, and we put them on blood thinners to lower the risk of stroke. Because stroke is a big consideration. People do not like to take blood thinners, but I tell people it's easier to stop bleeding than it is to deal with the stroke. Remember, blood thinners do not cause us bleeding, but if there's a little bleeding becomes a lot of bleeding. So that's one. A second approach is just to control the speed, put them on blood thinners, and we can leave them that way if it doesn't bother them, or we can someday say, let's try to put the heart back in rhythm. The third approach that we've seen, and it's been growing as time goes on, is a procedure called an ablation. And here is a picture of what it looks like, ablation, where we go up inside the heart, we find that pathway, and we sort of do a circumferential destroying of the atrial pathways, and we call that an ablation. Frequently, we're using that in younger people, or people that have an ablation, or some people that we put back in rhythm and they keep going out of rhythm, or they don't tolerate the medicines well. Then we say, well, now the benefits of ablation is worth the risk, especially if there's a weak heart, heart failure, the medicines fail, or there's a poor quality of life. When I first started, we rarely did the ablations, but now we're getting the technology, we're getting better and better at ablations. But remember, it's not for everybody. You have to talk to your provider. And the provider that does this the best is probably called the electrophysiologist. They can talk to you about the risks, benefits, pros and cons of this type of therapy for atrial fibrillation. Now, sometimes a person will start off and they'll have atrial fibrillation one time, we'll put the heart in rhythm, and then they'll go on for 5 or 6 years. Then they'll have it come out again. We'll try them on some medicine. That medicine might work for a while. Then they'll go out again and it will bother them. And we'll say, well, now you need the ablation. Or it won't bother them. And we'll say, listen, you're now to the point in your life, it's not bothering you that much. You're older. Let's just keep the heart speed controlled and keep the blood thinned out as long as it is safe. So that's sort of a general approach to atrial fibrillation. We still have some specific cases and specific conditions that I want to talk to you about more, and we're going to do that next time. Specifically, are there alternatives to blood thinners? What can we do if the blood thinners are too risky? What if a person doesn't want an ablation? There's some special considerations. What are the risks of some of the medicines we put people on? So I want to handle that in our next video together. But I don't want us to forget Acts 20, verse 24. But none of these things move me. nor do I count my life dear to myself. Remember, we're on a journey, a trip that's given to us by God, so that I might finish my race with joy. And each one of us has been given a life with something to do, and the ministry. God's given each one of us a ministry that we get from the Lord Jesus to testify to the gospel of the grace of God. So one way you can do this is you can testify that gospel by sharing this video with friends. You can like it, or you can comment something hopefully positive about atrial fibrillation to help the many other people that might be learning about this. Now, I wanted to make it simple, not too complicated, give you the basics of atrial fibrillation, something you could learn from and share. And next time we're together, I'm going to specifically talk about some special considerations and some special questions that come up for those people that do have atrial fibrillation. So I hope this helped you out a lot. Share it, talk about it, continue to pray for this ministry, and I'm going to be back soon with yet another biblical prescription for life.